All right, endocrine and metabolic disorders, chapter 7. We're going to go over our learning objectives is to be in an organized fashion, ID and treat all life threats in an organized fashion, obtain an accurate history, perform an examination, and then to formulate a diagnosis in an organized fashion. Take that diagnosis and create a differential diagnosis list and refine that differential diagnosis list along the way and to treat our patients. So the endocrine anatomy is a bunch of organs that secrete hormones. These hormones then are then sent through the bloodstream or directly to these other organs to then secrete and regulate other portions of the endocrine system. Here we see the posterior pituitary from the hypothalamus, and then we see the anterior pituitary, and what hormones does it regulate and how it works to create homeostasis within the body. One of these is called functions is the diabetes or diabetics. Our function from the pancreas secretes hormones, glucagon, and insulin through those islet cells, and it regulates our blood sugar. It also does this with working with the liver and the storages of glycogen, and so we can have glyconeogenesis, gluconeogenesis, and glycolysis, all increasing our blood sugar, and then if we need to, we can package and store those along the way. It also helps us in acid-base disorders, creating homeostasis. You have the lungs and the kidneys either secreting or retaining CO2 or hydrogen ions on either end of that. As we know, we have then the carbonic acid equation and blood that helps to buffer and hold on to some of these to help us in these shifts to rid ourselves of the acid that we produce. And these are just more of our buffering systems that we talked about. As we go through more diabetics, as they end up creating new sugars and new ways of creating energy. They're using fats and muscles rather than using the carbohydrates because of the inability of the insulin to allow sugar into the cell. And so they developed this manifestation of increasing urinary production, increasing ingestion of food, and then increasing of water intake. But in all events, they are peeing out all this excessive sugar and water through the renal system and out through the urinary system. Our difference between our type 1 and type 2, that we can start off with a type 1 reaction where the body senses that this is non-self or that insulin does not work at all. And then we have type 2s that progressively over time the body becomes desensitized to insulin and the pancreas can't maintain insulin levels. And we can end up becoming a type 1 in later stages of life. And normally we would in type 1 be taking insulin, type 2 be taking a type of pancreatic medication to increase the pancreas function, and then somehow allowing sugar to be utilized better until later ends we might end up being placed on insulin. Gestational diabetes occurs around the time when the female is pregnant. It does show her that she might have this propensity to have diabetes in the near future and develop diabetes type 2. The difference between hypoglycemia and hyperglycemia. Hypoglycemia, we see them being wet, pale, cool, diaphoretic, acute presentation of altered mental status, some type of history of already taking their medication, usually insulin, and haven't eaten. Blood sugar comes back being low. We know how to treat this. On the opposite end, there's more of an insidious thing where the person is warm, very hot, and is not hypothermic, where we're looking at the hypoglycemic. The hyperglycemic is taking a while, blood sugar is going up, they're not usually on insulin, they're usually on oral hypoglycemic, haven't been taking it. We end up finding out the 3 P's that's been going on. They're creating new types of sugar and creating ketone bodies, and this is increasing their acid production in their body, become a metabolic acidosis that goes on, and so their breathing becomes much more labored, and we know they end up in what's caused Cosmol type respirations, and they may have this acetone breath. So again, some of the signs and symptoms as we kind of go over. The Nonketotic. This person has a little more pancreatic insulin secretion, so they don't necessarily develop into the straight DKA, and so they are able to maintain some of sugar sources that are used, and so usually blood sugars kind of go up in time, and so this sometimes is usually differentiated in the first time that they're diabetes type 2, and not our diabetes type 1. It might be even the initial onset of our initial diagnosis of somebody who's now going to be diagnosed with diabetes type 1. Okay, so as we move forward, a lot of the diabetic acidosis and metabolic derangement due to the endocrine dysfunction, we're going to really try in a pre-hospital setting to tank them up, because that's pretty much all we can do. We don't give insulin. We don't try to correct the pH at that level unless they have a documented case where they have renal dialysis shunt, but you can consider that they have some kind of metabolic derangement if they're breathing heavy, if you think that they're seeing the peak T's in the QRS complex, or you may be even seeing a widening in the QRS complex changes, sine wave. Think about that as far as what you want to communicate early to get orders for. Case 1, we're developed here, we're dispatched to a 24-year-old person, goes laying on a couch, and the mom says that my son is diabetic, is very unstable, what you would say. It's just, they're not really sure how to treat this patient because diabetes is so brittle. Now, here's our ALS pathway. It keeps us organized, and we move forward. Initial observations, the scene safe. Mom's home, she greets us. We can think that potentially maybe this 24-year-old might become disoriented, confused, and even combative, so we might think about that person. But is there anything else that may be causing this person's initial, unresponsiveness or unconsciousness? Is there drugs? Is there other things that we need to be aware of? And we take a look. So we have a 20-year-old unconscious, breathing deep and rapid, and then an unplugged insulin pump. So this person was on a pump that's more continuous, that kind of monitors and regulates the glucose level and secretes insulin over time. And it seems like the pump is not connected, so let's continue and see what else is going on here. The little tachypnea, deeper breaths that are going on, and he hasn't been feeling well for days. So is this our acute presentation where the patient is pale, cool, diaphoretic? Is the person presenting hypothermic? Is their breathing and tachycardic more of the hypoglycemic, or is this person going towards the opposite side where they're more hyperthermic, more flush and dry, and peeing everything out and moving forward? Let's take a look at our primary assessment. It does have a response to withdrawal to pain. Airway is patent. There's no snoring type respirations, but we notice the rest of there's some crackles in the right base, and the skin is hot and dry. So he is sick, and we definitely need to start considering some of our differential diagnoses and what are our diagnoses so we can decide and then divvy up and prioritize our work and management of this case. So what are we thinking? Is this DKA? Is this HHNC? Is this hypoglycemia? Is this stroke? Is it because of the lung findings? Is it because of some kind of aspiration? Could this be an infection that's going on? What's going on? So we can use the AIU tips. We can chase the diabetes. We can chase neurological dysfunction. We can chase respiratory issues. Well, we got to do it in some kind of fashion. Here we have his history of present illness. Doesn't seem to be a lot there. We would know that he's seriously ill for 3 days there. And then let's go into the sample history. He's got some depression meds in there as well. And he unplugged his insulin pump, comfort foods. So we must have some issue as to why he wasn't using the pump and what could that mean. Let's look at other people again. We would either go into his history of present illness, OPQRST, dive into our meds and allergies, past medical history, or right into some type of examination, pupils, skin signs, track marks, tongue, incontinence, pulse rate, those kind of things. Here we have our vital signs, heart rates elevated, blood pressures holding, temperatures elevated, SAT's good, he's dry. You still got those crackles in the right base. Really confusing there. Is that some kind of respiratory? Aspirate, is it pneumonia? But then we got a lot of other things going on. cooking on the blood sugar, 678 is pretty high for us, right? Cardiac monitor 120, ST changes, no acute ST changes in a 12 lead. We got a pneumonitis, elevated lactate we would expect if the person has a blood sugar of 678. We're looking at a metabolic derangement and acidosis. Metabolic acidosis, we're showing on the ABG would be greater than less than 7.35. As far as the acidosis goes, they got a 12 lead here, and we're looking at this 12 lead. And what are we supposed to see? They're not really showing us anything. It doesn't show us to be a 12 lead where they were tachycardic. And so this is not the 12 lead we really want to look for, but it doesn't show us any kind of sine wave, doesn't show any kind of peak T's. So we're just moving along with that. And then we have our Untitled CO2 capnography waveform. It's kind of low to me. It's around there, the 35, I guess. We don't see the printout. So hopefully we're in our normal range of the Untitled. Again, so our differentials. And where do we go from here? You know, what is your BLS management going to be? What would be some ALS management? And then what was the critical care management issues that you would do to manage this patient? What kind of diagnosis are we thinking of? What do we think this patient could have?